Picture this. You're on the surgical wards knocking out your morning rounds. You've got a patient recovering from a pretty extensive surgical procedure, and honestly, everything seems to be going totally fine. But then, your pager goes off. Salam, welcome to A Little Push, 5 Minutes Medical Mnemonics. Let's get right into it. So it's post-op day number 3. The nurse tells you your patient suddenly has new-onset shortness of breath and a cardiac arrhythmia, maybe AFib. You rush in, ask if their chest hurts, and they completely deny any chest pain. No pain at all. So what exactly is happening here? Well, you need to have a seriously high index of suspicion, because this is the classic presentation of a silent postoperative myocardial infarction. And the literature backs this up, showing that 2/3 of these events happen right in this exact window, between post-op days 2 and 5.
All right, so when you identify a potential post-op MI, you need a reliable, rapid checklist to manage it without missing a beat. Enter your hero, the BE MOAN Mnemonic. This is an absolutely essential framework, not just for surviving your ward rotations, but for crushing your board exams. Let's break this down letter by letter.
Starting off, the BE stands for beta blockers. Now, what's crucial to remember here is that beta blockers are a medication that actually decreases mortality. You want to administer these as hemodynamics allow, meaning if your patient is hypertensive or tachycardic, because they significantly reduce the heart's workload and drop that myocardial oxygen demand. Basically, they let the heart rest.
Next up, M is for morphine. We definitely don't want the patient moaning in pain, right? Morphine is fantastic in this scenario because it doesn't just provide excellent pain control, it also actually reduces preload on the heart. That gives that stressed-out myocardium a much-needed break.
Moving right along, O stands for oxygen. This one is pretty straightforward, but it's absolutely critical. You've got to provide supplemental oxygen to maintain adequate oxygen saturation. We are specifically aiming to keep those sats comfortably above 90%.
And A is for aspirin. Just like our beta blockers, aspirin is a total wonder drug here because it also directly decreases mortality. It's your essential antiplatelet agent, absolutely crucial for preventing any further clot formation in those coronary arteries. Typically, you'll load them with aspirin and often add a second antiplatelet agent too.
Finally, finishing out the mnemonic, the N stands for nitrates. Nitrates promote vasodilation, which improves blood flow directly to the starving heart muscle. But hey, quick clinical pearl here. Avoid nitrates entirely if you suspect an inferior wall or right ventricular infarct. Those patients are heavily preload dependent, so nitrates can actually cause profound dangerous hypotension.
All right, moving into high-yield clinical correlations, board alerts, and diagnostics.
To truly excel, you've got to know the diagnostic traps. And I literally cannot emphasize this one enough. This is a massive board alert. You must clinically check for an aortic dissection prior to giving any anticoagulants or thrombolytics. An acute aortic dissection can perfectly mimic an acute MI. If you give thrombolytics to a patient who actually has a tearing aorta, that is a fatal mistake. No way around it.
So how do we safely rule it out in a pinch? Well, you need a careful clinical history and a rapid physical exam. Specifically, you're looking for unequal peripheral pulses or a noticeable blood pressure difference between the arms. Grab a chest x-ray to look for mediastinal widening. And if your clinical suspicion is still high, you've got to get a chest CT scan with IV contrast to definitively exclude a dissection before you even think about proceeding with MI protocols.
Let's look at the EKG and see how this builds out our diagnosis. With a STEMI, you'll see those classic ST segment elevations. But remember our scenario? Our post-op patient is often having a silent MI. In cases of an NSTEMI, the EKG might have 0 ST elevations. Instead, you might only catch subtle ST depressions, T-wave inversions, or honestly, just nonspecific changes.
And because those EKG findings can be so incredibly subtle in a silent NSTEMI, your diagnosis really hinges on cardiac biomarkers. Serial troponins, specifically troponin T and I, are the absolute most sensitive and specific markers we have indicating myocardial necrosis. You'll track these levels over the first 24 to 48 hours to lock in and confirm the injury.
Okay, time for a rapid review quiz to lock this all in. Let's see what you've got.
Here is the question. What is the most dangerous period for a post-operative MI following a previous MI? Think about it for a second.
All right, do you have your guess?
The answer is exactly 6 months after a previous MI. If a patient has had a heart attack within the last 6 months, their risk for a post-op MI is at its absolute highest peak. Great job if you hit the nail on the head with that one.
And that wraps up our explainer on managing the silent postoperative MI. Just remember BE MOAN, and always, always keep your index of suspicion high on those surgical wards. It kind of makes you wonder, right? What other silent killers might be hiding in plain sight out there on the floor? Thank you so much for tuning in to A Little Push. Make sure to subscribe for more 5-minute medical mnemonics that give you that extra edge. Until next time, salam.